ahead and I'm going to tell everybody a little bit about Soroptimist. Soroptimist International is an organization of volunteers who work to improve the lives of women and girls through programs leading to social and economic empowerment. We are a global volunteer organization that economically empowers women and girls by providing access to education, the single most effective anti-poverty intervention. Over 80,000 Soroptimists in 122 countries and territories contribute time and financial support to community-based and international projects that benefit women and girls. So that's a brief synopsis of who we are. And today we have our member, Rosemary Fox, and her
Eda
Anguiano, who also works with Rosemary. And since I failed to get a bio on either of them, I'm going to let them just go ahead and start. They work for, what is it?
By the Bay Health.
Thank you. Thank you, Rosemary. By the Bay Health, and are going to tell us a little bit about what their organization does. So thank you, ladies, for being with us, and go ahead.
So let me start, since I feel like you're all my sisters. And I have to say, I'm so proud to be able to provide you some additional information, which I'm hoping you'll be able to utilize or pass on. So as many of you probably know, and I hate to admit this, you guys, but it's my 50th nursing graduation year.
Whoa. Wow, congratulations.
Okay, so I won't bore you with my 50 years of working history, but you may know I've done a lot of different things throughout my career, and I chose to really end my career with an organization I felt could help not only your community, but my community. I've always worked either in San Francisco, San Jose, San Mateo, but not in Marin. So this was an opportunity to really give back to the community and be a part of it. So I'm very grateful for that kind of end of career hurrah, right? So today, I hope that both Eda and I can help you understand a resource we have available. And we really want people to be encouraged, if you want to know more, to reach out to us. But if you're just interested, it is a very valuable asset we have in Marin, Sonoma, and San Francisco. We can offer both our friends and family. So that's all I'm going to say about me, because I don't think it's about me. It's about what we're trying to represent. But I just wanted to kind of frame why I'm working for them at 70 plus years old. You know, so I feel so passionate about this topic, and I feel that I've been led here through the other experiences I've had throughout my career. So I'm going to pass it to Eda and let her tell you a little about herself. She has a very, I want to say, powerful and important career path that she's engaged on as well. Okay, Eda.
Thank you, Rosemary. Good morning, everyone. I'm super happy to be here with you. My name is Eda Anguiano, and I have been with By the Bay Health for almost 3 years now. Originally from Mexico, as I was talking with Sean before, and in my previous life in Mexico, I am a family care physician. So when I moved to California around 15 years ago, doing the validation was very, very troublesome, considering I had 4 young little girls. So I decided to go for the next best thing, and I started working for hospice. So my entire career since I moved has been doing this kind of role, bringing awareness of, what really hospice is into the communities. Most of my history has been working with for-profit companies. And finally, I had the opportunity to join By the Bay Health around 3 years ago. And actually, I was so excited that for 2 years, I commuted from Palo Alto. So I'm super excited to be with an organization that really represents what I believe in and when it comes to end of life. So I would like to start by sharing a very small PowerPoint presentation that I put together just to explain a little bit of who we are and who our organization is. So I'm going to share my screen. And there we go. Perfect. So everybody's able to see my screen?
Yes.
Okay, perfect. So is By the Bay Health. So I want you to know a little bit more about the organization that Rosemary and I am representing, and I will give you a brief overview. We were founded in Marin County over 45 years ago. We are the first hospice in the state of California and the second hospice in the entire country. We have been serving Sonoma County since 1992, San Francisco since 2003, and most recently, and it's not on this slide, I need to update it, San Mateo since 2021. We recently opened an office and hired local staff in San Mateo County to be able to serve the community. We also have been an affiliate of UCSF since 2015. You may all be familiar with our old name, Hospice by the Bay. And you may also be aware that we changed our name around a year ago, and that is only just to choose a name that represents who we are now as an organization. During the last few years, we have added other service lines to our model of care, and we offer these services to our community. We have hospice care, skilled home health care, palliative care, and pediatric care. So I will just give you a brief overview of what each one of these service lines entail. Hospice care, hospice is a specialized end-of-life care that provides pain and symptom management to help patients with terminal diagnosis live their best life possible for as long as possible. Our teams care for patients wherever the patient calls home. Some signs that a patient may be able to start considering hospice could be more frequent hospital or emergency room visits, an unexplained drop in weight, shortness of breath while resting, and even sometimes spending most of the day laying down could be a sign that the patient is near to needing hospice care. To be eligible for hospice care, a doctor must verify a prognosis of 6 months or less of life if the patient's illness runs its natural course. Unlimited extensions to this initial 6-month coverage are possible as long as a hospice physician confirms there's no change in prognosis. Anyone can refer a patient to hospice. It can be the patient, a family member, a physician, a discharge planner. Anybody can pick up the phone and make a referral to hospice care. Most of what we hear after families have had enrolled in the hospice benefit, so we hear our patients and the family telling us that they wish they had called us sooner so they could have benefited from our care for much longer. Patients do get the most of the hospice support when care starts early in their illness process. During the visits that we provide to these patients at home, we provide pain and symptom management. We provide medical care, including medical supplies, medical equipment, and hospice medications. We also provide counseling about practical issues, including healthcare wishes, planning for financial needs, tapping benefits or additional support from other agencies. Our team also helps ensure the physical safety of the patient in their living environment. And also as part of the services that we provide, we include personal care, which includes bathing, dressing when needed. Also, the team of clinicians that care for our patients, care for the patients and the caregivers and their families. We provide education about end of life. We provide caregiver education and training, emotional counseling,
Etta, I need you to
Yeah.
yourself. I'm sorry.
Yeah, I unmuted everyone. I think everyone was muted, right?
Yes, they are now. I was
Okay,
trying to get rid of that doggy. Sorry.
perfect. Okay, great, thank you. So we offer also home health care. Home health care is a wide range of healthcare services that can be given in a patient's home for illness or an injury. Home health care is usually less expensive, more convenient, and just as effective as the care as what you will receive in a nursing home or sometimes even in a hospital. Examples of what home health care provides for patients could be wound care for pressure sores or for surgical injuries. It could be patient and caregiver education, medication management, and just monitoring patients with serious illnesses and stable conditions. In general, the goal for home health is to treat an illness or an injury and help the patient get better, regain independence, become self-sufficient, and also to slow decline of the patient. In order to qualify for home health, a patient needs to meet 3 criteria. One is to be homebound. This means the patient is unable to drive or leave home or requires assistance from others to leave home. They also need a diagnosis or a treatment plan that requires nursing or rehabilitation. And they also need to be under the care of a physician that offers home health services. We also have palliative care. Patients of all ages are available to receive palliative care. In contrast with hospice care, palliative care patients are not required to have a terminal diagnosis, and they may begin or continue curative treatments at the same time that they receive palliative care. A typical patient that will use palliative care could be a cancer patient, a patient with, a chronic condition like, COPD, congestive heart failure, kidney disease. So some of those are the conditions that maybe a patient for palliative care could be, appropriate for. Times to consider palliative care could be when, the goals of care that a patient had don't align with, when the treatment plan does not align with the patient goals. We also have a pediatric program. So for pediatric, we offer palliative and hospice for children's all ages. We have infants, children, teenagers up to 21 years old. Because young patients may have the advantage of concurrent hospice or palliative care and ongoing disease-directed care. So these patients may be able to initiate or continue treatments with their specialty team, such as radiation, blood transfusions, chemotherapy, while at the same time receiving end-of-life care with the By the Bay Kids team at By the Bay Health. So this is just a brief overview of the services we offer. We offer additional services to the community, like community support groups. Sometimes, especially the last couple of years during COVID, we realized that staff in facilities, assisted livings and nursing homes were experiencing an extreme amount of grief. Not only they were losing their patients, but sometimes they lost even staff members due to COVID. So providing grief support to the community during COVID has been one of our main directives. We offer support groups for schools, for communities, for businesses. We have another program called Match. This program provides telephonic support for patients who have been enrolled in any of our service lines, like, for example, hospice. Some patients graduate from hospice. Some patients, after being on hospice for a certain time, they no longer have any decline and they no longer qualify for hospice. So we call patients graduating from hospice, meaning at this time, they are not having any decline. So those patients that disenroll from hospice still get a call from a nurse regularly to check how's their current condition. We also have, of course, within our pediatric programs, we have by the Bay Kids Camp that we do every year just to support kids and teenagers who have suffered some loss in their family. And that's, something that, it's a very important service to the community that we serve. We serve, like we spoke earlier, Marin County, Sonoma County, part of Napa County. We cover American Canyon and Napa. We are in San Francisco, recently opened an office in San Mateo. In Alameda County, that's more for pediatric patients. We don't have many hospice or home health patients, but we do take pediatric patients in Alameda County. Another thing about organization is that we are committed to a diversified workforce. We really believe that we need to serve our communities in a culturally sensitive way. So we make, efforts when hiring staff. We want to make sure that we have a diverse workforce to be able to serve the community and meet the cultural needs. During COVID, we had to do monumental efforts to communicate with the community, not only training our staff, but also the staff of the nursing homes and assisted livings that we partnered with. We found the need to work with their staff and train them in the proper use of PPE. And we also provided technology to some assisted livings that were not very technology savvy. So we donated iPads to communities so we could facilitate telehealth. So during COVID, when most of those facilities and nursing homes were close to visitors, we were able to see our patients and communicate with them via telehealth. So for that, By the Bay Health donated iPads to communities in all counties that we serve. And this is it for me, just when it comes to an overview of who we are. Now I'm gonna hand the mic over to Rosemary. Rosemary, would you like me to stay here on the presentation, or do you want me to stop sharing?
I think you can stop sharing for now. So what I'm really charged with is to be the director of home care and to actually get their home care program started. And that happened about 3 years ago as well. In the meantime, I've assumed oversight and directorship of the palliative program as well as hospice admission. So I kind of have my foot in all the service lines. Pediatric reports to me as well. So I'm pretty well versed in all the areas. So I'm just going to add a few points to what Etta said, and then I'm going to open it up for you to ask questions and get what you'd like to know answered. So I think when I talk about hospice, I have to tell you, one of the shocks to me were how many patients we had. We have 550 patients, which is a lot of hospice patients when you think about it. We have at least 200 admissions a month. So that's the churning rate you can figure out. And we have some patients that have actually been with us over a year, quite a few actually. The other thing that I was surprised by was how many people were called live discharges. So they got the benefit of the hospice service, but as Etta said, they stabilized, they've gotten the information they need, and they have been discharged from hospice. The big deal there is they get their Medicare benefits back, because one of the hardest parts, I think, of hospice is for people to understand when you sign up for hospice, you are changing your Social Security benefits to be all in the bucket of hospice. So you're no longer going to be paid for dermatological procedure you needed, because that is one of the things you give up when you agree that you're going to limit the care that you're going to ask Social Security, Medicare to pay for, bottom line. So that's the biggest and most important part when we admit our patients, to have them understand We identify your goals for life with your family members and really talk through, are you ready for this? So in other words, you're not going to run to the hospital every other week. You're not going to jump in an ambulance. You're going to acknowledge that you're really at the final stages of your life. And we're going to do everything we can to make you comfortable and respond to you. But you have given up these benefits. Now, while you're in hospice, if something changes, like, for example, your doctor said, oh, we found some new experimental drug we want to try on you, you can what they call revoke from hospice. So you can, undo it and go back to Medicare like right away. There's no waiting period or anything. So I just like to put that up front. So we're really spend a lot of time trying to explain to the patient and their families the conditions of this benefit, because they also give you additional DME. They give you additional support for some of your home care needs, like bathing or things like that, that may be really a burden for the family member to continue by themselves. So those are just a few things around the hospice service line I wanted you guys to appreciate. The second, I think, slide was really around home health, which is my area of expertise right now. And it's really focused on rehabbing someone. So we have all the therapies available to us, PT, OT, speech, and we are able to offer those to patients in their homes. They do have to be written by your primary care doc. We need an order that the doctor said this patient would benefit from any of these services. And then, of course, with that is a nursing component and social work service as well. Again, kind of assisting us with a full team approach. So again, we work really closely with the primary care doctors. That's different than hospice. Hospice will do it with your primary care, or we'll take it over. It can go either way, depending on what your doctor prefers. But with skilled nursing, we need the involvement of your primary care doc saying this is an appropriate service to provide this patient. Now, the next one is palliative. So most of you may or may not know what that is, because I have to tell you, even being a nurse for a long time, it's very vague. It's not paid for by Medicare. So it is a service that's been identified as a huge need. It's really complex case management. So most of the patients we have in our palliative program have at least 3 chronic diseases we're trying to help them manage. Again, we partner with your primary care doc, but palliative does not require a doctor's order, right? A family member can reach out to us and say, can you please help me? I have a mother, father, sister, brother who are really struggling. They don't understand the care. It's not coordinated. They're going to 10 different specialists, and they really need somebody to help set up a plan for them and coordinate what they're doing and why. So palliative care, because we're a not-for-profit agency, we're providing to patients regardless of their insurance coverage. Now, fortunately, we have some insurances that are willing to pay for this service because they see the benefit to the quality of care they're able to provide the patients. My personal belief is that palliative care will be incorporated into the Medicare benefit soon, because every demonstration project they do shows that it definitely improves the care and the outcomes of the patient and is very cost effective for Medicare. So it's not quite there yet. I know there's legislation that's all over the place and pending, but you will see that service being incorporated sooner or later into the Medicare benefit. Right now, we do not charge patients for the service. So if we take you on and say, we want to help you because your doctor said this person would really benefit, and you're eligible based on our criteria, and we think we can help you, we'll take you on, and there's no charge for that. So it's kind of one of those hidden gems that you can get some help without necessarily having all the insurance coverage that we wish you had, right? We use it as part of our charity benefit. As a not-for-profit, we need to have certain dollars. Pediatrics is another one where we fund it because it's our contribution to the community as a not-for-profit. Does that make sense, guys?
It does.
And then the pediatric program, it's a little niche. It has, I think we have 60 to 70 kids in it right now. They usually stay on for longer than our adult patients because we can do more for them. They have more openness about how their benefit is covered. So it's kind of a sidebar service. Nobody else really does this very much. So again, it's not a moneymaker, but it is definitely a value added to the community to have this service for these families. So I'm going to stop with that, Sean, because I don't want to take all our time, and make sure that you guys have a chance to ask me whatever you'd like, or Etta, either one of us.
Well, so far, what you've shared with us is just so helpful. I believe just the delineation and descriptions of all the different classifications of what you can provide. And I really appreciate what you at By the Bay Health are doing. Thank you. But I think we probably have a lot of questions, and we'll get to those. Let me unmute people.
Yeah, or you can use the
Okay.
chat screen too.
Okay. So let's see. Mari, go ahead.
I have a question. So Sutter Medical also has a hospice service, but they
Correct.
charge for that?
Well, hospice is never charged for. It's a
But
Medicare benefit.
But Sutter Medical probably does, right?
No, they shouldn't.
Oh, okay.
Because they are paid by Medicare.
Oh, because I was just wondering, why would a doctor suggest Sutter Medical over you guys?
Because it's maybe their affiliation,
Oh.
maybe it's their medical record. And to be honest, the whole premise is people have choice.
That's what I was going to ask. Do you have a choice?
Yeah,
I just went through a nightmare of a friend that got diagnosed with cancer, and it was quick. She got diagnosed and she was gone in 6 months, but I went through a nightmare with Sutter Medical Hospice.
well, I mean, Mari, it's never easy. And I'm not going to even speak to the difficulties, and different hospices have different points of view in the way that they delivered the service, but it really is dictated by Medicare. Now, how people treat you, how you feel, what the responsiveness is, that's more agency specific.
Well, I only hear good things about your hospice.
Well, the other important part, I just want to share this because I think it's why we're who we are. We were started by a nurse, okay, 45 years. It was all volunteer. There wasn't a paid staff member. So it was all through donations that she built this hospice service in Marin.
Mm-hmm. I remember that a long time ago.
Mary Taverna was her name. And matter of fact, her daughter-in-law still works with us. But the point I'm making is the reason hospices exist, or their mission, tells you a lot about who they are and why they do what they do. Okay, so whenever you're looking for any service, take a minute, go to the internet and read what they're about, their mission statement.
So palliative care, one more question
Yeah.
is it's helping someone who has several medical issues and not a
End of
impending.
life.
Yeah,
Right.
okay.
Well, what we try to do, because we only have so many staff, we try to really focus it on those patients who have a shortened life, though, like 2 years or so, because we just don't have enough bandwidth to take care of every patient that would qualify. So what we're looking at is, what can we do to help that patient? By our intervention, what can we do that'll make a difference? So that's kind of how we decide to take somebody or not. Can we help them? And is there a reasonable life expectancy that we can kind of gauge our care on? But it never hurts to ask and to try. If you think that is a service your family could utilize, I'm always willing to talk to you, but also we have intake people, and Etta can speak to that, even provider relations, that can give you the, nitty-gritty detail, and then you guys can decide. And again, it's a team approach. It has social workers. It has, I think, even some chaplaincy services we throw in there. We have not OT or PT, because again, that's more of a rehab get better, which is in the home health. Now, the other part that's so interesting, you can have both. In our company, you can have home health to rehab, let's say, a stroke. We can go in there and try and get that family member stronger, better. But let's say ongoing, they've got now, tons of, we can put them in palliative at the same time. Because palliative, we're not getting paid by anybody, so we're not conflicting.
Mhm.
You can have home health and hospice because Medicare is paying for both of them.
Okay, that's what I wanted to
So,
know.
yeah. So do you understand? That's really the difference, is Medicare assuming the financial liability of the case and where the boundaries are.
So what do you do if, just one more,
Yeah.
what do you do? So you give up your Medicare, but what do you do if you have an emergency situation? Like, say, maybe someone got an infection and they have a high fever and you feel like they need to go to the hospital. But I mean,
Yeah.
even the ambulance drivers will tell you, once they know someone's in hospice, they won't take them.
Right, because part of the agreement at the beginning is that you will not seek aggressive therapy. Now, with that said, Marty, we all know we're human and we change our minds. So if you, for example, had a family member that you felt had let's say they had a UTI and they were uncomfortable and suffering, if you either went to the ER, called your doctor, whatever, we can take that hospice benefit away even for a few days for that treatment to occur.
Wow.
And then you can come back to hospice.
Definitely. Just to add more on that, patients can revoke hospice at any time. So that's one of the conversations we have when we have a sit-down conversation. We explain everything that the hospice benefit entail, and we also present some options, right? So if the patient at some point decides to revoke because they decide, you know what, I want to give chemo another try, or you know what, I panicked in the middle of the night and I call 911, you can revoke hospice, and as soon as you went through that extra chemo, that other treatment, and realize, hospice is my best option, you can always go back and resign into hospice. So for many people, when we're meeting with, they feel like they're making this life and death decision by signing, when really hospice is as easy as just pick up the phone and call somebody from your team and say, I'm revoking hospice. It's not a process that is going to take time. And that allows you to go pursue aggressive treatment or emergency treatment, and then go back into hospice care afterwards.
And then Medicare will pay for that, is what you're saying?
Correct.
Yeah.
Correct.
Okay.
Yeah.
In conjunction with your regular health care provider.
Normally this happens when a patient goes into the hospital. So what we do is we just disenroll so Medicare can pay for that hospital stay. And then when they discharge, they enroll again on hospice service.
Is there a delay? Is there a paperwork delay though
No.
that you have to?
No,
patient
everything
has
It's
is
to-
immediate.
Oh, okay.
sometimes we even get the call from the patient and they're like, we're already at the hospital. We are in the emergency room. We advise when a patient is being admitted, if you feel you have to call 911, give us a call too, so we can disenroll. Some families in the middle of a panic situation, they won't do that. They call us when they're in the hospital, not a problem.
Okay.
Well, Sutter Medical didn't give us that option, so.
You know, Mary, I want to make a comment about that because, you know, it is important. And part of what my team does and my department does within the organization is to educate referral sources, but also the community at large, because it's important that we all know that we have choices when it comes to hospice. So now what the comment you're making right now, I hear that over and over again. There are some hospitals, like there are Sutter affiliated hospitals, and we our patients that even though they request us, they say, no, we are the official hospice, and that is not accurate. I mean, if a patient has a personal preference, that should be respected in a hospital. So part of our job is to educate community so they know, you know, hey, these are my rights. I have the right to choose whatever hospice organization I feel is best for my needs.
Mhm.
And
I-
the other thing I just want to add for a sec, if you have a friend that really needs help and you know they do, and they don't want to acknowledge a hospice goal, okay, they want to still seek therapy. That's what palliative can do, because you can get any therapy on palliative. We're not restricting meds, hospitalization, ER visits. Now we will follow up and see, why did that happen? Could we have done something to prevent it? So palliative is a great fallback to a service that will hang on to that patient, help them. And then when they're ready to move to really their end of life experience, or they have too much pain to just be managed by palliative, they can move to hospice. But the palliative, in my opinion, is a great holding space because we're watching you all the time. We're giving you ideas. We're saying, are you ready? Do you think this would help you? Because the other part we didn't mention is when you're on hospice, all your DME, which is your medical support equipment, beds, walkers, wheelchair, that's all included in hospice. Okay.
Thank you so much. This is so valuable.
It's a big deal.
I
Really.
would also like to know, Rosemary, does this apply also to Kaiser patients?
Yeah, Kaiser refers to us all the time
Okay, all right.
in relationship to hospice and to home care, especially in Marin. They have no real, we're their fallback. So Kaiser has a unique contract with us for home health because they can't take care of all the patients. So they'll send them to us all the time.
And
Well,
let's
Kaiser
say
has-
you are a Kaiser patient, and can you say to them that you would rather have
Yeah, you can ask, 'cause
hospice
if they,
or by the Bay Health?
Definitely,
Yeah.
definitely. Actually,
Okay.
we are one of the options they offer. We are
Okay,
their preferred provider. So when it comes to a Kaiser patient, normally, I mean, Kaiser is pretty good at that. They
Yeah.
offer options, but definitely we are one of their preferred.
now,
Wonderful.
the exception is palliative, because that seems to be driven by the Kaiser Medical Group, or, you know, Santa Rosa has a different philosophy than Marin. Our stance is, and I'll be very upfront, if there's a patient that is ready for hospice, but they don't want to make the commitment yet, we'll take them into our palliative program. Kaiser won't pay. Kaiser may want you to be in their palliative program, although like in Marin, they've discontinued home palliative services. They have clinics. So you can negotiate with Kaiser a little bit. And again, if you let our team know, either Ed or myself, we'll do what we can to support that patient because that's our goal. Yeah, go ahead, Rosemary.
Yeah, that was my question in regards to Kaiser, because you said you don't charge for palliative, and you think Medicare is going to soon include that in their benefits. But Kaiser doesn't pay for it either.
They say they do it themselves.
Okay.
So they're not denying you the service, but they have not contracted with us or any other palliative program as of yet. Now, when it becomes a Medicare benefit, then they'll have to reconsider.
Yeah, that's good to know.
I worked for Kaiser for 9 years, so I know that system pretty well.
Oh, good.
And I understand kind of the limitations, but also the wiggle room.
But some insurers do pay you?
Yes, and mainly those that have a Medi-Cal affiliation. For whatever reason, Medi-Cal covers palliative.
That's the state.
Yeah. So if you have Medicare, Medi-Cal, you're often part of a program that'll pay for the palliative.
Okay, that's good to know.
Again, it's so weird and different and complicated.
Yeah.
That's why I say to people, reach out and let us help you, because I'd have to know your situation and figure out how I can work it so you get what you need and the right service that you're looking for. So Mari, you now have somebody at your elbow. If you ever find yourself in that, you can always call me and we can strategize how to get what you need.
Thank you.
And anybody else for that matter. Okay, any other questions?
Nancy?
Yeah, I've had my hand up for a while. Rosemary, and you're all asking valid questions, and I have a few also. When you say affiliated with UCSF, does that mean that the doctors who are in the UCF system refer you, or what is the affiliation?
We definitely work with them directly, like Marin Health now has that same affiliation. We also do planning together. So there could be projects that they're looking for solutions for. They have a population health division to try and improve care for people at large, regardless of insurer. And we can partner with them. For example, we are taking care of some end-of-life patients for them at UCSF in the hospital, but they're hospice patients with hospice benefits. And that's an arrangement we've made. We educate their palliative fellows. They're part of our team that works with us. So we have all different kinds of connections. They refer as their home health patients, things like that. But we also share the same Epic medical record system, which is huge. So Marin Health, Kaiser, UCSF, and ourselves are all on Epic. That means we can share information across.
Thank heavens.
So
I know.
Then the other thing is hospice. In Marin, how many hospice services are there? 2?
Oh no, there's
How
more
many
than that
hospice agencies? Probably 12 right now.
Really? Great.
And I would say, I don't know, last year or the year before, we looked at our market share. We had like 60 to 7% of market share. Now we have all these competitors from the East Bay, startup hospices, all trying to get in here because we have so much of the volume.
So then there isn't any such thing as a hospice wait list, I guess, then in that case, if you have so many providers?
Oh, no.
No. And, even ourselves, if you called and you said you were interested and your family member was eligible, we could either admit them the next day, even the same day if they needed comfort care, but within a couple of days at the most. We don't put people 5 5 or 6 days out. It's usually not more than 2.
Okay, and then what about palliative? You must have a wait list there, or how do you determine? Is it first come, first serve, or how do you determine who's actually going to meet the bar?
Well, I think what we do is people call and say would like palliative services, and then we investigate. We have no wait list right now because people, number one, don't even know or how to use it, because insurance carriers are not referring them, right? They're coming through private doctors or like this conversation. So right now I have 80 palliative patients. I probably could realistically take care of 100, and then we're adding staff. So we're committed to this. Sometimes you can't oversize until you have enough volume. And I have to watch how much I can lose, to be honest. How much can our charity care afford?
Right,
now,
you're
we
a
still
business, you're a nonprofit, but you still have to make your money somewhere along the line.
Yeah.
So
We
that
have to
actually,
be sustainable.
yes, and that actually left, I just have 2 more questions. It actually led to the staffing question, because we all know that there's a staffing shortage in everything. And especially this frontline nursing stuff. So many nurses have been quitting because of COVID. They're just burnt out. So how are you able to keep that line? I mean, because you have probably all different levels of nurses involved, but still.
150 spread throughout the company, something like that. The thing that's interesting about COVID, our hospice nurses continued through using Zoom, FaceTime, and things like that, and went and saw patients when they really needed to be in person. And they wore all the protective gear. They were basically very safe. And our home health nurses continue to see our patients with full PPE. Okay. The nurses, none of our staff got COVID from the patients. They got them from their husband or the wedding they went to, but we have not recorded among our staff, any of them, nurses or not, having COVID that was related to an incident in caring for people, because they're wearing all this protective kind of gear, if you will. So therefore, I think, to answer your question, Nancy, it wasn't the same in-depth dying patients that they were seeing in ICU. You know what I mean? That was a different reality for those nurses. Our nurses, number one, are used to death and dying. And number two, our number of COVID patients who actually were home weren't very many.
Yeah, but what I'm saying is that the nurses you're losing a lot of nurses for whatever reasons, and people are moving to better jobs. There's a constant turnover now.
Yeah.
I mean, it's happening in every industry. People are job jumping to the next opportunity. So you're definitely paying minimum wage, but are you competitive?
No.
Are you competitive?
Yes.
Yeah.
We're not only, we did a full market study 2 years ago. We're not only, I can't say we cannot compete with Kaiser, quite frankly. Kaiser is, a different kind of, what do I want to say, system whereby they increase the premiums to be able to afford the higher salaries. Okay, that's how they do it. I think some people choose to work for an organization they feel they can achieve their nursing and social work goals. So we're very appealing on that level. We have been very flexible on our ability to let nurses take their kid to a soccer game and come back and go to work after, right? To stay home and homeschool their kids and do their job remotely. So we have been super flexible and done our best to make sure our nurses are supported.
I appreciate
that. There's definitely a shortage. I mean,
I appreciate that you're appreciating them and trying to make some accommodation to them. And this is the very last question, and it's more personal about it's more personal about each of us as individuals. What about long-term care insurance? Where do you think that fits in to this picture?
Well, we have nothing to do with that. It's really about the skilled service somebody needs. Long-term insurance is so interesting because I've heard pros and cons. It's really about having reassurance that if your family member needed residency, really more than care, that they need to be in a residence that are going to do all their daily living. They're going to have their food. They're going to give their medication. They're going to have somebody there at night. You know what I mean? So it really depends on your personal family situation, I think. It depends on if that's a good investment because it's super expensive. So you really have to make a choice. We don't do any of that kind of, what do I want to say? It's not part of our service. Kathy?
Thank you. Thank you.
Sure.
Kathy, you need to
Kathy, you're muted.
My husband's parents in Point Reyes, they both had long-term health care, which they used. But then he got to the point where he had to have hospice, and I think they got it through Marin General, and it was set up before he even left the hospital.
But yes, and that, again, I don't know if it was with us, but we work with Marin General. They don't do any hospice.
No, but he
But
wasn't allowed.
Saturday-
He wanted to go home to die, and they said you could only go home if you get a hospice, and it was arranged before he even got home.
Yeah, regularly in hospitals, we get the referrals from the discharge planner and they let us know, hey, this patient needs extra support, they need extra help. So what we do is we meet with the patient and the family in the hospital, and we even order the medical equipment ahead of time because the idea is that the transition between hospital and home is very smooth.
Yeah.
So we have nurses in the hospital overseeing and having this conversation with patients in the hospital and making sure that, you know, an ambulance has been set up, that if the patient, you know, is in severe pain, do we have the medications? So what we want to make sure is the patient does not go through any distress. But yeah, you're right. Normally when a patient leaves the hospitals, they are already with an assigned hospice agency.
Okay, Sean, you might be the last question.
Okay, well, my question is, I would think, as in many things, that hospice care would differ greatly from state to state. Is that real? Is my thinking?
You know, it's a good question, Sean. The Medicare benefit is the same. It's a
Okay.
federal benefit. It's
So
not
it's
a state benefit.
So it's a matter of doing the same thing, doing your homework and finding out which hospice would provide the type of service.
Absolutely. And let me tell you a little bit of why, right? I mean, hospice is a Medicare benefit. Every hospice gets the same reimbursement per patient across the board. Now, how every agency chooses to spend those Medicare dollars, that's up to every agency. Medicare has a minimum requirement when it comes to number of visits. So Medicare says, at a minimum, a nurse has to visit a patient every 14 days. So some agencies will go by that, right? They will say, okay, we're gonna send a nurse every 14 days. In our case, that's not enough, right? Or nurses come at least twice a week if the patient is stable, let alone if the patient has symptoms, right? So yeah, you're right. All hospice should be standards, but that is not the reality. Even with local agencies, some agencies emphasize, like one example that I can give you, we don't spend a lot of money on marketing. We don't bring food and treats and, you know, take people out for like fancy dinners and dine and wine like other agencies do to work on their relationships. I mean, our philosophy is money should go into patient care. So that, I think, to your question, yeah, all hospice should look very similar, but it's up to every agency to decide how to spend that Medicare allowance.
Well, thank you very much, Etta and Rosemary. I mean, this has been so so informative. And I'm a nurse, and there's a lot, and I've had a lot of experience recently with family members needing hospice care, but there's a lot I didn't know that you just shared. Thank you.
Absolutely. Like Rosemary said, please don't hesitate to contact her or contact myself. I'm going to follow up with my contact info, Sean. I'm going to send it to you so you can send it to the rest of the group. And
Great.
if anybody has a personal circumstance, just a random question, please give me a call.
Okie
Same
doke.
here. Okay.
Well,
Thank you.
I again thank you, and I'm sure everyone here does. So
Thank you.
people who will be watching our recording. So
Wonderful.
thank you very much, ladies, for coming again.
Oh,
Thank
for
you so
sure. It's
much.
our pleasure.
Pleasure
Bye.
to meet you all. Thank you.
You too.
Thank you, Etta.
Bye-bye.
Thank you, Rosemary.
Bye-bye.